So the metronomic adjuvant chemotherapy is something which is different from the conventional cytotoxic chemotherapy. So it's giving tiny low doses of chemotherapy, and the second drug is usually Celecoxib, which is a non-steroidal anti-inflammatory drug. And sometimes we use triple metronomic, which is using erlotinib, which is an anti-EGFR drug. So that works different. Its metronome is like small frequent dosings of the drug. So the study randomized patients with locally advanced head and neck squamous oral cavity. So oral cavity is the predominant type of head and neck cancer in India, and the oral cavity cancers who underwent curative surgery and then the standard therapy, that is either radiation or chemoradiation, based on whatever the stage and the guidelines are. Once they completed that, they were randomized to either observation alone or they went on to the metronomic chemotherapy arm. So they took those two tablets, Methotrexate once a week and Celecoxib twice daily, for 18 cycles, that is 28-day cycle for 18 cycles, or roughly about 18 months. And in this study, again, the primary endpoint was overall survival. So there was a numerically higher survival. So 79% of patients at 2 years were alive with the metronomic chemotherapy compared to 70.2% in the observation arm. However, it did not meet the statistical significance cutoff, and that was because the study was kind of underpowered. It did not complete the recruitment because of multiple factors, and then the investigators, we all decided to, with the new evidence, with the immune checkpoint coming in this space, close it because the time of recruitment had passed and there was new data coming in. So the study closed at 412 patients, or 410 patients, and it was supposed to close at 712 patients. So there was a numerical increment without it being significant. So there seemed to be some signal that metronomic therapy improved the survival. And when we did an exploratory subgroup analysis looking at which patients got the benefit, so the very high risk subgroups seemed to have a higher benefit. So probably our population was heterogeneous, and the benefit that was actually would have been seen if it was enriched for these poor adverse prognostic was probably lost, or maybe the inadequate sample size also could have contributed. So the finding was there seemed to be a signal, there is a numerical benefit, but that didn't reach the statistical significance. So maybe there needs to have some more studies, or maybe refine it, incorporate immunotherapy, look for biomarkers or some novel strategies in this space.